The session on acute myeloid leukemia has just finished here in Rome at the Blood Cancer in the Elderly conference, and I'm very lucky to have Fernando Ramos from Hospital de Leon in Spain. Fernando, what for you is the reason for taking such an interest in AML in the context of older patients?
Well, this disease is upsetting for our patients and also for us because it has a very outstanding mortality rate. And overall survival is very, very low, and much less, than 10% of our patients are alive after a year.
And how much does the age of a patient make to AML? How much difference does it make if you have an older patient?
Well, first of all, he's elderly, and that's absolutely different because many of the elderly people don't have the opportunity to receive high dose in chemotherapy. That is now one of the main weapons we have for fighting against cancer. And on the other way, some of them don't want to receive this sort of chemotherapy because it compromises quality of life.
Do you think that as a community we are concerned enough about treatment for elderly patients with AML?
No, absolutely not. Sometimes people have some caveats regarding even the economics that has to do with elderly populations. Discrimination regarding age sometimes also has to do with economics. Who is the best population to spend our money? Obviously, if you have a life expectancy of 40 to 50 years, probably a lot of people would think at the early beginning that the best thing would be to give our resources for the young and instead of the elderly. But that's a sort of discrimination we must fight against.
You are suggesting, though, that intensive chemotherapy potentially bringing benefits, or intensive therapies bringing benefits, might not be used in a number of older patients. How do you decide which patients intensive therapies could be used in?
That's a difficult issue at present time. We don't have the appropriate tools for making these decisions. Probably there is a wide clinical practice and variability among the different hospitals and different doctors, and that's not good at all. What we should do is to have what is called CGA, the comprehensive genetic assessment. But that's something that takes time. You need a lot of resources. We need to work in a properly engaged multidisciplinary team, and that's something we don't have everywhere and in every hospital.
Now, at the session that you've just taken part in, there's talk about cytogenetics, there's talk about adverse cytogenetics, a particular subgroup of patients who are going to do poorly. You've also were discussing how AML may be different entities within the same disease. What came up?
Well, since the WHO organization changed the AML classification, a relevant proportion of what was earlier called MDS has moved into the AML world, let's say. So now there is a relevant proportion of AML patients that have low blast counts, and many of them, most of them, are elderly patients with poor risk cytogenetics. And these people do not benefit from intensive chemotherapy, and we must look for alternative pathways for them.
What sort of good things do you see coming along?
Well, now we now have low dose, low intensity chemotherapy, and that's good news. Now we have some data that low dose chemotherapy do benefit patients with AML with a low blast count. What we don't know so far, and we are trying to get the data for translating that into clinical practice is whether this sort of therapies might also help those patients having more than 30% bone marrow blast cells. It seems, because according to the French compassionate use program, the bone marrow blast cutoff of 30% is not a key issue regarding its activity.
And how much hope should we hold out for the effectiveness of some of the more gentle therapies, some of the more targeted therapies in the future?
Obviously, it expands the opportunity to give something not very aggressive to sometimes frail patients. So it's been a huge change. The problem is we need some additional time and a lot of additional data just to try and see what patients would benefit more.
So what would you say to doctors who are faced with elderly patients with AML, perhaps those who might have been categorized as MDS in the past, who may be frail or may be fit? What should clinicians be thinking about now, finally?
Well, in the survey we took during the session, we could see that just a very, very tiny proportion of the doctors in the session chose intensive chemotherapy for these AML patients. Probably it's not something that we have discussed a lot, but we have the feeling that we must change something in these sort of patients, that we must try another different pathway from the classical one, that it's always just to choose between just supportive care and intensive chemotherapy. That dichotomy is terrible for the patients because most of them cannot receive intensive chemotherapy. And there is a third pathway. The new way should be just to try and test the low-dose therapies, low-dose chemotherapy.
Fernando, thank you very much for joining us here on eCancer TV.
It's my pleasure coming here.